Thank you, Dr. Butler. And so we're going to spend the next 10 minutes discuss the radiobiological aspects of LDR prostate brachytherapy. Obviously, this is too big a topic to be adequately covered in a 10-minute presentation. So the primary goal for this talk is to provide a quick introduction to the topic. And some of the topics will be discussed more systematically in tomorrow's presentation in the treatment planning session. But anyway, I think one of the nice things about the summer school is we will be here all the time through the rest of the several days. So we can get the conversation started and continue the discussion afterwards during our time here. So the learning objective for this presentation is try to get acquainted with some of the radiobiological models that is relevant for examining the LDR prostate brachytherapy, and also become aware some of the key radiobiological features of LDR prostate brachytherapy and their potential clinical implications. As you heard in the talks this morning, LDR prostate brachytherapy uses seeds permanently placed inside the prostate gland for dose delivery. As a result, the cancer cells and the normal tissues are subject to continuous low-dose radiation. Because of the radioactive decay, so the dose rate actually decreases exponentially with the time throughout the treatment. And also when you use different sources with a different decay half-lives, the time it takes to deliver a major portion of the therapeutic dose, for example, 90% of the total dose, can be quite different between different sources. For cesium-131 and iodine-125, the difference is between about 1 month to 6 months. So radiobiology provides a scientific framework and useful tools to examining the potential impact of such different temporal dose delivery patterns on treatment outcome. Now, as we will discuss more detail in tomorrow's talk, and radiation-induced cell killing or cell survival has been often used as a surrogate of biological effects. Among the cell survival models, the linear quadratic model is the most popularly used. And has anyone here have not heard about the LQ model? Now, no hands raised. I can skip this slides and conclude the talk. But anyway, so the simple version of the LQ model applies to acute irradiations. For protracted dose delivery used in LDR brachytherapy, a generalized version has to be used so that some of the time-related biological processes, such as cell repopulation during the treatment and also DNA damage repair, can be included. Now, one can do the study using this formalism, and however, in practice, this so-called biologically effective dose introduced by Professor Jack Fowler is often used. When the linear quadratic model is used for the cell survival, then the biological effective dose is fundamentally the same as the LQ model. And the quantities in this big bracket after the dose is often referred to as the relative effectiveness, as it's a modifying factor to the physical dose in order to get to the biologically effective dose. The reason that the BED is used more often is because when the cell proliferation can be ignored, and when the repair are absent, then the BED is related to the dose by a ratio of alpha to beta instead of 2 independent parameters. And it can be used to compare the relative effectiveness of different treatment techniques, and it can be used for iso-effective calculation. So the application of LQ formalism to brachytherapy really took off after the late 1980s, when Professor Roger Dale worked out a analytical formalism for this projection factor, dose projection factor. So with this relatively simple closed form, this model captures the interacting effects of dose delivery, decreasing dose rate characterized by the decay constant, and the cell DNA damage repair, and also the cell proliferation during the treatment. The formula as written applies for uniform dose distribution or for a point dose in the inhomogeneously distributed dose. And in addition, it assumes the biological properties of the tissue can be characterized by these 5 parameters. And the gamma is basically is this factor, so it's related to the effective tumor double index. AAPM TG43 has endorsed a self-consistent set of parameters for calculating biological indexes and for the purpose of improve intracomparability for people reporting such analysis. Now, the other assumption is the DNA damage repair follows a mono-exponential kinetics. In addition, the proliferation rate remains uniform. Now, with this last assumption, it also requires an additional assumption that the BED has to be calculated at a so-called effective treatment time when there is a cell proliferation present. And the assumption is that the BED calculated at this time point is adequately representative of the biological effects of the implant. Now, the reason that we need this effective treatment time is illustrated in this slide. So in absence of cell proliferation, and you can take the time limit to infinity as we're doing the permanent implant, and you can arrive a mathematically well-behaved quantity. When cell proliferation is present, now because the proliferation rate was uniform and the dose rate decreases exponentially over time, so as time goes on, there is a certain point where the cell kill, the rate of cell kill caused by instantaneous dose rate is going to be starting equal to the proliferation rate or eventually become lower than that. So when you take the limit to a infinite time for the permanent implants, the BED becomes negative. So this effective treatment time is defined as the time at which the cell kill, the rate of cell kill produced by the implant equals to the proliferation rate. So the definition of effective treatment time is physically intuitive. And the conclusions drawn from these model studies confirms generally to the clinical observations. However, conceptually, it has remained as a point of concern. So Professor Michael Zeiders and his colleagues have proposed a iso-effective dose model based on the theory of stochastic cell birth and death processes. And when the linear quadratic model is used for the cell survival, and it can be shown this IED model is well behaved at a time limit, time takes to the infinity. And as you can see on this graph, it appears that the magnitude of the IED calculated are always larger than the BED calculated at the effective treatment time. Now one can argue if you use this as a relative index, probably it doesn't matter. So the question is whether when you use these models, when you try to derive a iso-effective treatment, whether that's still, are they equivalent? So in a recent study, it was found if we're using iodine 1 to 5 as a reference treatment and calculate the iso-effective prescription dose for sources with different decay half-lives, the prescription dose derived using BED is always lower. It's also always lower than those derived from the IED. And in the situation for this nominal parameter set where the effective doubling time is about 42 days. The differences are relatively small. However, for faster growing tumors, and this can be dramatic. So the clinical significance between these two models still remain to be tested. And historically, BED has been used more often than IED in the brachytherapy world. So in the following, I'm going to do a quick run through of some of the radiobiological features of permanent implant using the BED model. The first question we want to ask is whether the biological effect is the same when we deliver the same dose using different radionuclides, isotopes. And in this plot, it shows that sources with a shorter half-lives appears always more effective biologically compared to those with a longer half-lives. And we can do, so in theory then, when we deliver the implant using cesium-131, if we were prescribing the same dose, then the cesium-131 will be always more biologically effective. Now you can do this kind of study for other radiobiological parameters involved, such as cell proliferation rate. And you can do that for DNA damage repair. You can do that for the alpha-beta ratio. So the interesting thing is we know alpha-beta ratio is an important parameter that affects the sensitivity of the a biological system to dose fractionation, especially for when we're moving towards hyperfractionated treatment. Now, because implants doing a continuous low-dose radiation, so we're in the sort of extreme hyperfractionated treatment. So if you look at this, then the response or the dependence to the alpha-beta ratio is actually relatively small, especially for long-lived isotopes such as iodine-125. However, when you move to a short half-life sources, the differences increases. So if we were using cesium-131 to deliver a treatment for a normal situation, such as head and neck, where the tumor has a larger alpha-beta ratio than the normal tissues, moving from iodine-125 to cesium-131 will actually lose therapeutic ratio. And obviously, so for prostate, because the alpha-beta ratio is equal or smaller than the normal tissue, then moving towards cesium-131, you may actually gain in terms of the therapeutic ratio. So I apologize for running with it. I'm going to do 2 slides, and then I'm going to conclude. So now with this discussion, so now we kind of understand why the prescription dose for cesium-131 and iodine-125 are different. So they're generally prescribed lower. And if you calculate with the AAPM TG137 endorsed parameter set, the BED actually come out relatively close to each other. And because of that concern, initially cesium-131 was actually prescribed to a lower dose, starting with the 105 to 110. And in those situations, in fact, the biological effectiveness actually is lower, can be about 10% lower. So one can see the implants with the current prescription is pretty much equivalent for a prostate with a longer doubling time. And that may not be true when the prostate have different proliferation rate. iodine-125 generally is a little bit more effective for slower growing tumor, and short-lived half-life, short-lived isotopes are more effective against the tumors with a faster growing tumors. So anyway, so I'm going to skip this one because in the sake of the time. But to point it out that for prostate, LDR prostate implant, one of the unique things is the procedure-induced edema. And the edema introduces another temporal variation in the prostate implant, which can have an impact on the BED and the tumor control. And when the edema is present, the short-lived isotopes may not be always more advantageous in terms of producing the biological effect compared to the long-lived isotopes. There are many applications which are documented in the write-up, and I wish I had time to tell you. But in the sake of the time, I'm going to conclude. So the unique spatial temporal dependence of LDR brachytherapy can have a significant impact on the biological effects of the implant. Radiobiological models are useful to try to understand some of the features related to this particular treatment modality. And the current models are good for relative comparison for different treatment techniques and for patients with maybe for patients with different radiobiological characteristics. And a good understanding of the model and the model limitation is important whenever we perform such analysis. Thank you.